hypertension. So etiology of resistant hypertension, one can be suboptimal therapy. Most commonly, if you are not giving the drug in full dose and still the BP remaining high and you label it as a resistant hypertension, then it's not right. Suboptimal therapy remains the first cause of resistant hypertension. Then extracellular volume expansion, poor compliance with the medical. This is also very common. Patient don't take medicine properly and then blood pressure remains high. Secondary hypertension, of course, we'll discuss each and every cause later on in the lecture. Then white coat hypertension, pseudo hypertension, ingestion of substances that elevate the blood pressure, that is drug induced hypertension, and side effects of many antihypertensive drugs. So what is suboptimal therapy? Most common and most correctable cause of resistant hypertension. Most of our general practitioner or physician, anybody, if you are not giving dose of antihypertensive as its full dose, then it is not going to act properly. If you give suboptimal dose and still the blood pressure is not managed, so it is called a suboptimal therapy. You have to give full dose, then only things will be under control. So this is the most common cause. Then second cause is extracellular volume expansions. What are these conditions? Most patients has relatively or absolutely extracellular volume expansion under the underlying conditions, that is renal insufficiency, that is renal failure, patient who are on dialysis, sodium retention due to vasodilators, ingestion of high salt diet, presence of clinically occluded occult expansions, use of once daily or short acting loop diuretic. These are the causes which leads to extracellular volume expansion. When extracellular fluid gets more, and these blood leads to blood pressure. Then next is poor compliance. That is, poor compliance means patient is not taking medicines properly, and which leads to resistant hypertension or repetitive hypertension, noting of repetitive higher blood pressures. So poor compliance is one of the most common effects. So you have to check with all the patients daily basis whether he is taking pills properly, whether he is not taking pills properly. You have to ask during the follow-up, then only you will come to know with the history. Lifestyle modification, obesity and low salt diet, alcohol intake, these are very common associated problems along with the resistant hypertension. Then next is secondary hypertension. Up to 11% of the patients with refractory hypertension have identified secondary causes. So what is secondary hypertension? The blood pressure is higher because of some secondary problem. These can be renovascular hypertension, then it can be a primary aldosteronism, then it can be pheochromocytoma. You all know that pheochromocytoma is a suprarenal gland tumor which can lead to hypertension, and these are the secondary causes of hypertension, which is pheochromocytoma, aldosteronism, or renal hypertension. So correcting these problems of pheochromocytoma, operating that, aldosteronism correction, or renal hypertension, correcting the renal insufficiency, will automatically reduce the resistant hypertension. Next is most common, office or white coat hypertension. What is this white coat hypertension? Whenever the patient comes to a hospital and whenever doctor checks the blood pressure, usually the patients become anxious and blood pressure shoots up, and that is called, a patient becomes anxious and blood pressure shoots up, that is called as white coat hypertension. So development of such white coat hypertension, for managing these white coat hypertension, we have to manage 24 hours ambulatory BP monitoring we should do. And if all the if only the readings when the patient is visiting the hospital, if those readings are high, then only called as white coat hypertension. Otherwise, if all the readings are normal, that is to be ignored, or reassurance to the patient should be given. Or whenever a patient comes to hospital, nurse or any other attendant can take the blood pressure instead of a doctor. So 24 hours BP monitoring can give good prognostication to the, it can diagnose white coat hypertension. Now, next is pseudo Hypertension. Pseudo hypertension is also very important. So what do you mean by pseudo hypertension? With the old age, all the arteries in the body get stiffened or calcified, and these calcified or stiffened, thickened arteries are not giving a proper contour to measure the blood pressure. So whenever anybody measures the blood pressure, it gives a blood pressure of a higher range. This is called as pseudo hypertension. The blood pressure in the in the artery is less, but due to thickened artery or calcified artery, usually it shows a higher reading. This is called as pseudo hypertension. So these are the potential causes of pseudo hypertension. Okay, the next important slide would be drugs causing hypertension. So whenever you are evaluating resistant hypertension, you have to also see whether it is drug induced or not. There are many drugs like NSAIDs, glucocorticoids, mineralocorticoids, or cyclosporin. These are the drugs usually causing blood pressure on a higher, causing hypertension. Steroids usually cause hypertension. And if these drugs are going along with the antihypertensive, these drugs should be discontinued for managing the blood pressure. Sympathetic overactivity is one of the most common causes of resistant hypertension, where cardiovascular disease, diabetes, insulin resistant, obesity, renal diseases, dyslipidemia, hypertension, these all are associated with sympathetic overactivity, which leads to hypertension. This is always sympathetic overactivity is most commonly associated with hypertension. This is proved in animal models as well as human models. There are studies which have proved these. Excuse me. Then obesity. Obesity, raised BMI also in associated with high sympathetic activity and high sympathetic nerve discharge, and leading to hypertension and also causing resistant hypertension. Of course, I have already discussed links with renal factor, sympathetic overactivity, renal diseases, then left ventricular hypertrophy, congestive heart failure. These all associated diseases leads to hypertension or hyper sympathetic activity and leading to hypertension. So the main question remains: how do you diagnose resistant hypertension? Now, if you have a patient coming to you whose blood pressure is more than 140 by 90 millimeters of mercury, continuously you're checking, you have to do then 24 hours BP, ambulatory BP monitoring. Once 24 hours ambulatory BP monitoring shows blood pressure is higher, then check for the patient's adhesion to the antihypertensive therapy. If you notice that at home the blood pressure is normal in the ambulatory BP monitoring, then only this is called as office resistant hypertension or white coat hypertension, which requires no treatment. Reassurance is the treatment. Then once the BP is higher in all the readings, you see the adherence of the therapy with the antihypertensive. Check for patient assumption of any interference of the drugs, whether he is taking any other drugs like NSAIDs, corticosteroids, mineralocorticoids, or cyclosporin like drug. Then identify and treat possible cause of secondary hypertension. Patient should be evaluated for secondary hypertension like sonography, 2D echo, and routine blood. If nothing is found, then optimize and titrate pharmacological therapies. Use the drugs to its maximum potential. And then if all 3 to 4 drugs are used, ACE, ARB, beta blocker, calcium channel blocker, diuretic, and still the blood pressure remains higher, then it is labeled as resistant hypertension. So usually there is a autonomic dysfunction in these patients. So managing autonomic dysfunction is also main thing. The objective of the therapy for resistant hypertension give the adverse effect of sympathetic overactivity and the development of complication. Reducing sympathetic overactivity should be the goal. The primary goal should be reducing sympathetic overactivity, which is seen in these patients. So central sympathetic outflow is there. There are alpha blockers, there are blockers. We all know that we have been using commonly these drugs, clonidine and methyl dopa, especially in pregnancy. We use this centrally acting drug. Now what happens, these are preferably alpha blockers, alpha 2 agonists. But the second generation which we are talking, moxonidine, is second generation. These are I1 agonist. So I1 agonist, what is the difference between alpha and I1 agonist? Alpha blocker generally blocks all the receptors which causes sedation. So clonidine or methyl dopa or not commonly used, clonidine we commonly use, these causes also the sedation. These sedation effects are negligible or not there with moxonidine because these are specific blockers. These are imidazolin receptor agonist. Drugs which selectively stimulate I1 sorry, I have been saying blockers. These are agonists, stimulate. These stimulate I1 receptors in medulla and reduces central sympathetic outflow. How they centrally acting, these in medulla, these stimulate I1 receptor and reduce sympathetic outflow, and these are not causing any, without any causing sedation. So moxonidine very commonly used nowadays and very effective drugs. So moxonidine, to talk about this specific drug, moxonidine 200-fold more selective I1 receptor agonist than any alpha 2 receptor compared to clonidine. They don't have any sedative effects. So it is very potent drug and with less side effects. So there are many studies going on and proved that there is a role of moxonidine even if they use as a monotherapy comparison with other antihypertensive. Though personally, if you ask me, I don't prefer moxonidine as a drug in a monotherapy. I always go according to the guidelines starting from ACE-ARB or calcium channel blockers in older age group. And if it is not managed by 1 to 3 steps, then only we go for centrally acting moxonidine drug. But still, there are studies who also quote that monotherapy is also effective therapy for managing hypertension. There is a role in obese, elderly, uncontrolled hypertensive patients. So there are many studies quoting that Moxovas or moxonidine, to be specific, is a very potent drug as a monotherapy, even as a monotherapy, and especially in elderly hypertensive groups. I will not quote each and every study because there are a lot of studies saying the same results and conclusions. So there is also a role of moxonidine in suppressing obesity-related hypertension. So if patients are obese, you think there is a sympathetic overactivity. In such patients, you can directly start moxonidine to suppress the sympathetic activity for the better outcomes. There are also Indian clinical trials which are also showing the similar results and showing the monotherapy effect, or especially in patients with obesity and uncontrolled hypertension, moxonidine therapy could be used safely and effectively. Indian trials have also proved its potency. So pharmacokinetics, if you ask about Moxovas, absorption is 90%, bioavailability is 89%. This is also very important. The peak plasma level after taking a tablet, it reaches within 30 minutes to 120 minutes. So indication in mild to moderate essential hypertension, yes, this can be used, Moxovas. There are studies quoting starting of the antihypertension therapy with Moxovas in mild to moderate cases. Of course, resistant hypertension cases with metabolic syndrome, obesity, diabetes, or chronic renal failure, Moxovas is the drug of choice, centrally acting drug. Doses, we all know that dose is 0.2 to 0.3 milligrams once daily, may be increased up to 0.6 milligrams per day for week, but usually it should be given on a divided doses. At a time doses should be avoided due to uh, uh, it should be avoided at a time doses can cause hypotension. If you are giving single dose, then it should not exceed 0.4 milligrams. Uh, it should be avoided with beta, along with beta blockers as much as possible. Of course, it can be used in renal failure patient, but patients who are not on dialysis having chronic renal failure, might moderate renal dysfunction, then it should be used metabolically. It should be meticulously used. In pregnancy, should be avoided as much as possible. There is no much data saying they are contraindicated or they are indicated, but it should be avoided in pregnancy and lactation. Precaution, I already discussed with you. Cessation of combination with beta blocker. Beta blocker should be stopped first, and then moxonidine can be started after a few days. Use with caution in patients with a history of angioedema. Very important. Severe coronary artery disease, Moxovas should be avoided. Unstable angina patient, Moxovas should be avoided. Moderate renal impairment, patient who are in between uh, mild to moderate cases of renal failure, they should be avoided with moxonidine. So what are the advantages? The antihypertensive effect is comparable to all other class of antihypertensive. The potency of the drug is very good. Moxonidine improves metabolic profile of the patient, especially patient with diabetes, renal failure, and obesity. This improves the metabolic profile of the patient. Useful in patients with metabolic syndrome. Yes, everywhere, every study, this has been mentioned that this improves the metabolic syndrome, and how it improves is suppressing the sympathetic activity of these patients. The antihypertensive effect lasts for at least 24 hours, and therefore it can be administration once daily. That is what the main crux is. It longer acting antihypertensive. It is safe and well tolerated and has less potential for drug interaction. Only thing should be avoided with beta blocker. Safe and effective in combination therapy as well. So if you ask me, I personally, what is the take home message for this particular thing? When you are dealing this resistant hypertension, moxonidine is a very good drug for managing the resistant hypertension. For to start with the first drug in managing hypertension, I personally don't recommend it as a first drug of choice. Of course, it has been proved in many studies that it is as good as other drugs in potency with antihypertensive, but this cannot be the first drug of choice. Of course, for resistant hypertension, definitely Moxovas should be the drug of choice. Thank you.
Thank you, sir, for the excellent presentation. I have a few questions. If you permit me, I can ask you those questions, sir.
Sure.
Great, sir. So, sir, just to understand your experience on the molecule moxonidine, you mentioned a few things like obesity, hypertension, and CKD profile. Has there been any experience of yours where you have used this molecule earlier in the therapy? Like, as in, I'm referring to the guidelines and everything, that they wouldn't have moxonidine as a second line or a third line, and usually is being prescribed as fourth or fifth. Is there any experience of yours where it is used earlier and the patient has benefited?
See, it all depends on the what is the profile of these patients. as recommendation says, you have to see the age of the patient, whether it is less than 55 and above 55, and then go according to ACE, ARB, or calcium channel blocker, or a diuretic. This should be the protocol to start with the treatment. But if the profile of the patient is metabolic syndrome, diabetes patient, and obese patient, then or Pickwickian syndrome, patients who are snoring at night or having neck obesity, central obesity, moxonidine can definitely be the first drug of choice.
Lovely, sir. That's a opener to, I think, because most of our Indian in the Indian scenario, most of the middle to elderly age group is obese because they are majorly home based. Second would be the neck obesity that you're talking about, the neck patch, which is a heavier patch, and snoring is one of the commonest observed and less reported event seen with most of the Indian population. So I think there is a big scope of using the molecule moxonidine in such patients for early effectiveness. Probably after an ACE or an ARV, the patients can be prescribed on moxonidine to have the best effect. So what would be the recommended starting dose as per your experience, sir?
I think 0.2 would be ideal dose to start with, and depending upon what combination therapy you are using and how, for what reason you are using. For renal failure and CKD patient, a much higher dose is required because their blood pressure is never managed by conventional therapy of calcium channel blockers, ACE, ARBs, diuretics. So they definitely require a centrally acting drug, and then alpha blockers or I2 agonist. These drugs come in the picture. So these patients would require a higher dose, maybe 0.3, 0.4 at maximum, or 0.2 or 0.3 BID dose can be also recommended for these patients. But to start with, I think 0.2 half dose also can be, if the score tablet is there, can be recommended for particular indications of these obese patients, diabetes, obese patients.
Perfect, sir. And so you mentioned about even giving this molecule as twice daily, and I believe the safety when it comes to other of the same class, maybe clonidine or prazosin, which are the basic drugs used as a third or the fourth line. Compared to them, the efficacy being as equivalent, but when it comes to the safety or the tolerability, moxonidine has a better profile. What is your opinion on it, sir?
Definitely, I think clonidine can be used, but the side effects of the clonidine, most common is sedation, and these side effects, to avoid these side effects. As far as the potency is concerned, yes, these are potent drugs. Definitely, clonidine is also a potent drug, but Moxovas is equally potent. As far as prazosin is concerned, it's an alpha blocker, and I think it has got a very specific indication for pulmonary edema, heavy patient. Congested patients. So prazosin still can be lower down. To me, if you ask me, I would put moxonidine much higher than prazosin to start the antihypertensive therapy in resistant hypertension.
Perfect, sir. Thank you, sir. Thank you for answering my questions so patiently, and also for the wonderful and enlightening session on resistant hypertension. I am sure the listeners would have gained deep insights in managing the patient better using the learnings from your session. Sir, we at McLeod's would like to honor your vast experience and your kind heart to share the same on such a platform for the benefit of the current and future listeners. Uh, I take this opportunity also to thank each and every participant attendee who has taken his time out from his busy schedule and has respected our invitation to be a part of this scientific feast. Sir, Dr. Sanket Nevale, representing medical team at McLeod's Pharmaceuticals, on behalf of the marketing and sales team, I would like to thank you for supporting us in this scientific endeavor. I wish you a great day ahead, sir. Thank you.
Thank you so much. Have a good day.
You too, sir.
Thank you, sir. So I'm ending the meeting now.